Hello, everyone. My name is Asma Syed, and I'm a second-year medical student at the UT Rio Grande Valley School of Medicine. My presentation today is called Double Seronegative Neuromyelitis Optica, a case of optic neuritis confounding stage 3 cervical carcinoma. So just a little bit of background. Neuromyelitis optica spectrum disorders are severe diseases of the nervous system, and they're characterized by immune-mediated demyelination of the optic, nerve, and spinal cord, as you can see in Figure 1. Optic neuritis attacks in NMOSD can cause blindness, and they're very rarely seen in paraneoplastic syndromes. So, in our case, we had a 40-year-old woman present with past history of stage 3 cervical carcinoma, bilateral nephrostomy tubes due to obstructive uropathy from a cervical mass. She had hypertension and anemia, and she presented to the hospital with worsening lower abdominal pain radiating to her back, a 10 out of 10 intensity, and a 2-week history of painless progressive bilateral vision loss. So upon physical exam, the eyes showed absent pupil reaction bilaterally. A CT was done of the abdomen and it showed moderate bilateral hydronephrosis and a right hydroureter. A lumbar puncture was performed for suspected intracranial hypertension, but the CSF analysis was non-remarkable. A brain MRI showed no metastasis to the brain and no intracranial abnormality as well. And then we did an MRI of the orbit for complete bilateral vision loss workup, and it did indicate optic nerve swelling consistent with optic neuritis, as you can see similarly in Figure 3. Then a right percutaneous nephrostomy catheter was repositioned after her abdominal CT showed suboptimal placement. And then a repeat MRI of the pelvis for obstructive uropathy confirmed a significant neoplastic infiltration of the pelvis, including architectural distortion of the uterine cervix, a likely malignant neoplasm extending to the superior wall of the bladder, and extensive infiltration of the ovaries. So, diagnosis and treatment of this patient. The patient was diagnosed with neuromyelitis optica spectrum disorder and was started on high-dose steroids and 5 cycles of plasmapheresis under neurology recommendation before initiation of carboplatin and paclitaxel, with a high suspicion for this being a paraneoplastic syndrome. Then neurology workup for serum antibody to aquaporin 4 and anti-myelin oligodendrocyte glycoprotein were negative, interestingly. The patient reported slight vision improvement after initiation of chemotherapy, indicating an ability to see shadows and slight imagery. And then the patient was discharged on latanoprostein eye drops and continued outpatient anti-neoplastic therapy. So our discussion section is next. And so optic neuritis is a clinical diagnosis based on patient history and imaging. Magnetic resonance imaging of the orbit and brain often shows acute demyelination. Further workup is needed for painless bilateral blindness and for patient presentations with additional neurological signs and symptoms to determine what is the cause of the blindness. Causes of NMOSD or causes include neuromyelitis optica spectrum disorder, and another cause of blindness is MOGAD, which is myelin oligodendrocyte glycoprotein associated disease. Differential diagnosis of neuromyelitis optica is often facilitated by seropositivity for anti-AQP4 in up to 80% of patients in cell-based assays. Very rarely is double seronegativity for AQP4 and MOG antibody seen, and that was what was actually seen in our patient today that I'm presenting about today. Lastly, the last point I'd like to emphasize is that paraneoplastic neuromyelitis optica, a syndrome involving remote immune responses to tumor cells that cross-react with nerve tissues, can be considered when vision improvement follows chemotherapy initiation. So in conclusion, this case describes an unusual presentation of suspected paraneoplastic neuromyelitis optica spectrum disorder. Thank you for listening to my presentation.